Assalamu alaikum. I'm Dr. Morshada. Welcome you to all. I think I am audible clearly. If any problem with voice and or screen, please let me know. Here I am, first of all, today's agenda is to discuss about MRCPCH regarding our the UK perspective and others. So it is a one type of discussion about career in pediatrics and MRCPCH. So actually, it's for the beginner, those who are here to who are here to know more about this. Many persons are joining. I mean, just to admit them. Okay. So I want to reassure you that please, when I complete my discussion with MRCPCH, so please ask me questions. Feel free, so that it could be helpful for you. Okay, whatever your query, I try to solve it. Okay. And another thing is here, it should be two-way discussion. Okay, so that we can come to know, because from 2017 actually I am thinking over this immersion and many things. So I comes to know many things I want to share with you peoples. Okay, hopefully it will be useful for us, everyone. So let us start. So first of all, it is well known that MRCPCH is the membership exam of the Royal College of Pediatrics and Childhood, and it is the one type of exam which having 3 exams. Okay, so and please take care your mic, so that we become distraction free. Okay, please mute yourself. We will discuss one by one, then you will unmute. Okay, so MRCPC is 3 exam, comprised is 3 exam. Among them, we call it that it is a theory exam and the clinical exam. Broadly, if we want to divide, okay. And everything is in the their website. Okay, nothing like if I said something new, it is not actually useful until they give it is the website. So always follow their website. Everything they update on their website if the changes occur. Okay. So we said that it is 3 exam. It is called actually part 1. It was previously called part 1, part 2, and the clinical exam. It is well known by this way: part 1, part 2, and the clinical exam. But certain changes that occurs many days ago, many years ago, and it is the part 1 which is divided into foundation of practice, that is FOP, and theory and science, that is CAS, and applied knowledge in practice, AKP, is the second part. So we get 1, 2 for the part 1, and part 2 is the AKP, and after then the clinical exam. So 1, 2, 3 here, FOP, TAS, AKP, we can say that it is actually theory exam. Okay, it is a theory exam and then clinical exam. So you can think that first, can I take part 1 later, then part 2 before, and then yes, you can do. Okay, so you can do first part 2, then part 1, or first part 1, then part 2. But clinical exam, before completion of clinical exam, you have to complete the theory exam, must. And there is a certain years, like if you complete your theory, I want to say that the difference between the theory and clinical exam should be 7 years. It is not that you have to pass clinical exams within the 7 years of theory exams, not like that, but you have to take the test. If you complete the theory exam and you didn't take any step for the clinical exam within 7 years, then your theory will be invalid. Is it clear or not? Please write in your chat box. We can again explain it, no problem. That is, you have to complete the theory exam, that is 1, 2, 3, and then you have to appear at the clinical exam within 7 years. Okay, but it is not like we will have to pass within these times, but within 7 years of completion of theory. And now, if you ask me that I want to give part 2 before or part 1, what's your opinion? And if you ask me, no, I want to go for only FOB, only task. So here there are different opinion. Okay, some experts say differently. No. So Dr. Rajiv, you question. Okay, I will explain it. Before then, you see, I said, what should I do? First applied, first AKP first or part 1 first? So in that cases, I will say it has different opinion, but RCPCH recommendation is to complete first part 1, then part 2, then others. Okay, so it is the RCPCH recommendation. And my opinion is, if you have first clinical knowledge, you are senior enough and you are like you have senior with the experience, then you can go for part 2 first. Okay, so clinical experience, if they are, then you can go for part 2, then go for part 1. Yes. Okay, but if you go for part 1 and then part 2, I think it is better. Why? Because everything having some similarity. So first of all, we should know what is the FOB, what is the task. Okay, after then it will be more clear. So foundation of practice, actually it's a clinical diagnosis, investigation, management. These are their things. So you have to make the diagnosis, you have to know the investigation, and you have to know the management. And theory and science is, they do not ask you directly the diagnosis, but behind the diagnosis, what is the pathophysiology, what is the risk factors for our disease, and then investigation and management. So very similarity between the FOB and TAS. Okay, they are very similarity, and you can give separately FOB and separately TAS. But I think that the preparation should be simultaneous. Like both FOB TAS simultaneously, you take preparation, and then you can
everything else is failed.
बस माता send का save का send का.
Okay, so first you will take the FOB or TAS. I hope you understand me that it has very similarity. So please be prepared with the both simultaneously. That it would be after then when you book the exam, you can take it separately, or you can take it single. So FOB then TAS, because some persons having problem, like they cannot take much pressure. Okay, so it is the exam which needed 2.5 years. It will start morning and it takes up to the noon, and then according to UK time, then at the evening task start, it is 2.5 years. So you see 5 hours time you have to give for the exam day. So it depends that you are taking time or not, but it's better to give. I think I like, for personally, I like to complete FOB TAS as a whole. Okay, I do not want to take pressure, same things reading again for the task, because many similarity. Even in my exams, I get same question FOB and TAS. Okay, first when I give the FOB, I think that yes, these questions already asked in the FOB, so I have some confusion, but I do not try to solve it, because this question will not repeat in the task. But surprisingly, same type of questions in the task. So you get it, that there are very similarity, but theory and science having some extra tasks. but foundation of practice is not that much. Okay, but yes, more difference we will discuss. And then AKP exam, if we take, then it's like diagnosis, management, more complex and more elaborate. And also there are many imaging for tools. These are the things that you should know. And now the clinical exam is there, but before then you have to complete. So there was a question that 7 years, if you fail, then I have to give the theory again. No, you have to give again the failed exam, but it is not the that you will give for similar theory again. It's not like that. Okay. Actually, if you do not give the exam, it means you are not preparing and your theory is invalid. Okay, but when you give the exam, it's need much money, so certainly you are preparing. Okay. Okay, now another thing is many students ask me, I get many messages, I require OET. In the whole MRCPCH system, there is no need of OET. Okay, English fluency test is not needed here. And even for the clinical exam, you need not to give any training certificate. Okay, this is the major things you should know. But English language test is not required, but simple English, saying simple English is required for the clinical exam. You can, as a medical student, you understand simple English and you can say simple English. It is usual. Okay, it's very normal, but need not to be band 7 for OET or IELTS. It's not like that. And also no training certificate, but for the clinical exams, you have to have a supervisor on you, they ask supervisor names and their mail address. Okay, so this supervisor could be your like hospital seniors, even admin panel can be give you this supervise as a supervisor. So need not to be, they have to be MRCPCH holder. It is not like that. Okay. Minimum gap with each of the exam parts to be given. It is like you have to apply. It's not, they do not give you any minimum gap, is there have to be in between the exams. They do not give any minimum gap. Okay, it's not written anywhere, but after giving FOB task, if you want to apply the AKP, that times 3 months is at least you what happened during my part 1 exam. I gave part 1 and without knowing the part 2 exam, I applied for part 2. Part 1 exam's results already is not my hand, but I applied for the part 2 exam. Okay. So it is not like that. Here no minimum gap is required. It's not right in their website or anywhere. So you have to apply. That means in the they give you the exam date and the opening date of the your application. That times you have to apply. And during this training, I want to clear it that yes, they do not say any training, but like after training, after giving the MRCPCH exam, you have to have a training in the UK for consultant position. Okay, so when you complete the MRCPCH, it means you are eligible for ST4 level doctor for the UK only. Okay, if you want to work in the UK at the NHS, National Health Service, so it's in that case government level. So in that cases, you are eligible to start your training, ST4 training. Okay, so that times you can start your training. That's it. It's not consultant level. Okay, you are completing. That means you are. So they do not ask any training certificate, because after completion, this you cannot independently work in the NHS. You can start your training, and training would be 5 years, would be 8 years. But if you have much if you have much experience, in that cases you can shorten your training. So you can go for consultant within 2 years even after joining the NHS. So there are different pathways. So I will check the message later, okay? So just put your message. I will check later after complete this. So exam system is in-center system is there, and also online system. Online system, even like some country having center, still they can give for online, and some country having no online, no center, still they can go outside and give the other country like in center exam. So two system here, okay? One is online system, another is test center. So both of them have to use their computer, okay? And they use the internet. But here, when you give the exam through your personal online, so in that cases, responsibility goes for you to make a stable network and to make a stable computer. That's the difference. And in center, they will make a like a stable network and everything. So as I am living in Bangladesh, so I want to say here no available center, but yes, available center in India, Pakistan, Saudi Arabia, Dubai, Myanmar, many places. If you go through the website, you can find it. And this online system, when I gave the online system, that times large seat always remain there, okay? Like we are not very much confident that times how it would be, but nowadays it has so much positive feedback that they keep it, although the COVID restriction is withdrawn, but they do not withdraw. So what happened now, to make us sit for online, it is now so much difficult that within I heard that within 30 minutes, sometimes within 1 hour, all the seats become booked. So nowadays, exam booking is another competition. You have to be very ready for this, and during the especially for the online system, you have to be have to take all the things in hands, and when they open within these times, you have to hit the website, okay? And another things for who wants to maintain their privacy for the female, they can ask for female invigilator. And exam booking date, okay, usually it is 2 months before the exam, 2 months before the exam date, okay? Like now AKP exam booking is open, it is open from 6th, okay, 6th March it is open, but the exam now it is March, but exam is May, okay? So you see they give 2 months, at least 2 months, 7 days before they open their booking, okay? Now how you give the payment, it is by the credit card, okay? But you cannot do it by your debit card. Before COVID, there was some systems like you can give others way, but nowadays payment procedure instant, you have to complete your payment. So if you want to give exam, you have to talk with your bank, because every country have different exam so payment procedure and different restriction rules. Every bank have different restriction rules. So at least before that, you have to you have to talk with your bank. Another things, before payment procedure, you have to complete your registration as early as possible. Okay, it is said in the website that 10 working days before the application periods were open. Application period open, that times if you go for registration, you can't give your money for the booking. So registration have to be complete. If you go through the registration site, you can take this. Okay, if you go through this. And also now in the website you will there is a site where it is written that registration signing, so you have to give some documents of you, especially primary qualification, that is the MBBS degree certificate you have to put. Then fees is very, please just look every time before you give the money, you have to look the website. Okay, it is differ from due to the like pound, if they give as a pound and you have to convert it with your own currency. And it is starting time is at the UK time. Okay, and you see here FOPTAS is on the same day, morning and evening, and AKP also 2 parts, but it is morning evening, but same topics. Okay, it is not like different topics. On the exam day, you need a passport with photograph, and it should be at least 6 months validity. Passport should have at least 6 months validity, and signature should be there, must be current, not okay. And all you can take driving license or NID you can take, but I think passport would be more good. Okay, and admission documents. Okay, now how you read for this MRCPCH part 1. Okay, how you proceed with this MRCPCH. So actually MRCPCH, if you go to the website, you get some books. Okay, so first of all, foundation of practice, here they published clinical case book for FOP. It's very important books. Pediatric guideline, it is always the update 2 years, 2 yearly they update it. It's a recent guideline, and case book is having no update version. Okay, they published it, after then they do not give any update. Okay, and some topics from neonatal guideline. Neonatal guideline is very huge, so it is not possible for to read everything. But pediatric guideline also, pediatric guideline is even for clinical exam. Okay, so not everything you have to read, but some important things are there that you have to follow. And very, very important things is recall. Without recall studying, pass marks is very difficult. Okay, so recall file is very important. Recall means we recall. Okay, after giving exam, we did. We recall, yes, these things came, these things came, and we make after giving the recall, after giving the exam, when the result is out, so we find that yes, I have all the what I gave answered, and I gave 100% 100% marks. Okay, so I can see that yes, my answer is right, so another person said no, my answer, so we can discuss and make a file. Okay, it is usually done by the Arabs doctor. They are very much helpful, so they may usually make these files. But I want to say opinion vary. Okay, sometimes they when they having some wrong questions, they give marks for all. So sometimes or confusing question. So recall files means not 100% right. Okay, if you get some files and they say that yes, it is the right answer, it doesn't mean it is 100% right. So always you have to be careful with the recall files. And sample paper file is, it is from the RCPCH. They give some sample paper as a sample. Okay, you have to see this. Then illustrated textbook of pediatrics, it is like you should have read it as a when you have less clinical experience, then you can read it, but you have to read it must, it is not like that. Then if we go for a task, what things we have to read? Again, here task case book, pediatric guideline is there, and science of pediatrics, that is SOP book. Okay, so these books is especially made of a very nice book for task exam, but it's a huge book. Important things is they give some box. Okay, so these are the things important. Otherwise, everything memorizing is not possible, but it's a huge book. Okay. Jury notes means recall file for the pharmacology. And everyday medical ethics, actually ethics question is very difficult, confusing. So it is there. Statistics, also there is some books for statistics. It is not recommended by the RCPCH. They do not give any recommended books for the like pharmacology, ethics, statistics, but we can take help from it. So recall files, very important sample paper, but I want to say not go for a faster subscription. It takes 300 USD. It's equivalent to my course. Okay, so I think it has no importance. Just if you need, then you can go for my Telegram channel. There are some I upload this past test. Okay, so past test, very recent copy, do not need to read, and it's very difficult to memorize, and it has not any recommendation. But if you compare with the MRCP, they read past test, okay, past medicine, different things, but MRCPCH is different. Okay, without past test, you can easily pass, okay, if you just follow the others. So question type, how it is: single best answer, best of 5, and extended matching question. So single best answer, every answer could be, but you have to take the most specific, most like best answer. Okay, and extended 5 option, best of 5, same. There is short clinical scenario, there is 5 options, and you have to take the one. Extended matching question are different. It is a 10 possible answers will be there, and 3 scenario will be there. You have to choose one. Okay, so this is 2 hours 30 minutes each exam, and you will get EMQ, that is extended matching 6, and okay, and SBA 79 question, and theory and science same. But we can, no one can say that from respiratory system they will give you only 7 question, 10 question. They never can anyone say. Okay, it is not defined. So sometimes from respiratory questions more, sometimes neonatology question more. So you cannot say that from where the question is. And even this EMQ 10, but sometimes it is 11, sometimes 12. Okay, 70, 77, 73, 74, they give the result as a percentage way. Okay, and if you go through this link, you can get the sample papers. So preparation time, many of you ask what is the preparation time, how much time I require, how much time I have to give. It is depends. I see many persons like they join my academy, and surprisingly they say, I want to give exam after I want to I booked the exam. So how you give the exam? You just join. So they ask, ma'am, give me your recording. I will do your class as well as recording, and then I will give the exam. They understand that they can, and they give much time. Within 3 months, they give the exam and passed. Okay, there are many example on me. Okay, so they so it depends how much time you can give. So 3 months also possible if you give maximum time. Okay, and you have good clinical experience. Another things, on an average 6 months if you want to give the exam comfortably. So after booking of your exam, if you will book the exam, and after then 2 months at least you have in your hand. So that's the very good. If you take preparation and then 2 months, if you read attentively, you can pass. Okay, but you have to prepare on the you have to prepare. Okay, so you have to prepare the your maximum effort you have to give. But and I always say maximum effort can be given, but passing way is different. Okay, like someone give maximum effort but get minimum, and some give minimum get maximum. So it is the way. You have to know the way how to pass the exam. Okay, if you take any mentor help, then they can help you like this way, and they can help you in these regards. So opportunities around the globe. So I want to say there are various opportunities after MRCPCH. So one most good opportunities in the NHS, if you want to work in the NHS or UK, then there's two way. That is the PLAB exam. It is the registration exam for the UK, and after completion of PLAB exam, you can work as ST1, 2, 3. So according to your experience. But if you complete the MRCPCH, you can just jump to the ST4 level. Okay. This is the one way. After another things is your Middle East. You can work in the Middle East, and they give if you have local degree, they give much value MRCPCH than your local, the best degree. Okay, like you are working in India, and here it is the best is I know MD. So in that cases, you have MRCPCH, they give more value. Okay, and also if you work in the UK as a fellow, you want to take the MTI, that is the medical training initiative. Like if you want to work in their pediatric hemato-oncology, okay, you want to do the fellowship in the UK. It is 3 years fellowship, and it's developed for the developing country, who will go there, take their training, and then come back to their own country and then serve their people. So in that fellowship also, if you get the MRCPC, then the getting fellowship is easy. Nowadays, getting fellowship is very difficult because it is totally paid fellowship. Okay, you do not have to spend £1 even. So it can be gateway for the whole world. Even Australia, you can go from after completion of MRCPC, but you have provided 2 years training in the UK NHS. Okay, then you can also apply for Australia. Fellowship Middle East country as well as Malaysia, it's a very good opportunities. And also you in your own country, if you complete the MRCPCH, you can work as a pediatrician. Your knowledge will be enriched. And the exam system is such a good way that you will get practical knowledge. You can help people even in your country. If you do the private practice in your around your home, in that case also it could be helpful. Another way I want to mention you, like some people's required, like after giving the FOP exam, only FOP exam, you can go for DCH exam. Okay, so it is a clinical exam, DCH. So after completion of DCH, you can take this DCH recognition. With the DCH, you can apply for the license in the UK, but in your home country, you can use this DCH. Now I want to say that I started after completion of my theory exam. Okay, so after completion of theory exam, I started after MRCPCH helpline. Alhamdulillah, this after completion of this, I have many students who successfully passed, and they and if you go through my the Facebook page, website, group, and also my if you go through the WhatsApp channel, everywhere you get many good review. So I just say you how I did this. And I try to help people as much as people. So it is I complete like total theory I divided into like in the system wise, okay, like CVAs, then respiratory system. So all the syllabus I divided into this. Then I take class 2 class per week, and total 36 class and more actually. So usually 4 months long course. Then I take for the each topic I gave PDF. Okay, so if you go through this, like for dermatology, I all my students take this PDF. If you go through this PDF, it's enough for you to understand or like what you have to read. This PDF is enough. If you have less time to go every books, so you can use this. Like I take it from the recall questions are there, so sample paper questions in my mind. So and then I take from case to pediatric guideline and from recall and whatever is needed, I put it here. Alhamdulillah, inshallah, there is if you just read this PDF, it will be enough for passing the exam. Okay. And also there is another recall after completion of the theory. I start a recall file. Okay, so I gave the recall file when I delivered my lectures. So that times also recall I give so that they can prepare by this way with the recall and the PDF. But after completion of the things, we start recall group also. So in the recall group, we discuss the recall who started with me the full course. In that cases, they can automatically join with the recall. Okay, recall group. And with every topics, there is some question answer. So usually in every week we arrange a exam. You can give the exam and assess yourself. Okay. And this is the whole way by which I want to give the exam. I give to try to help, and also at last we will take a final mock for the FOP and TAS separately. Okay, multiple exams actually preparation would not be complete. So this is the way. Course fee are very minimum. If you send me the in my WhatsApp number your query, I can share with you more. And there is a recording class option is available. If you have less time, you cannot give a schedule way, so you can take a recording class, and no extra charge is required in that cases. You join the group, you can remain the group until you pass, but you have to be active. Okay, so you are remaining the group and you are not giving any sound, you are not communicating with me, and so I will keep always in my group. It's not like that. So you have to be active, then you can remain in group and you have to share with me your problem. Okay. And certainly I want to say that we are arranging live class. Okay, so it's not recording class. We are arranging live class. So it is such a way that we involve our students. Okay, and they are, I should say, my colleagues. So we are communicate each other. Okay, and we in the class I ask questions. So I have many feedback. You can go through this, you can understand this. So live class is more preferable. I want to say those who already join in my course, in that cases, I want to say, please take care your camera, if camera is on. So, so you see that here I want to say that when you start a course, you should try for life. Otherwise, you will be distracted. Like after some days, you feel demotivation. So if you remain in the class, you always get motivation. Okay, you will be regular in that cases. So I hope it's not a very difficult exam. Really, it is not very difficult exam. Just you have to follow me. No, other than this, I don't think that you do have to give much extra effort. It's not like this. I always say, just follow me, and make contact always with me, so that I can help you. Okay, and always ask question. So all of you who joined already, I want to say again that just do not miss class. Sometimes it could be missed. Even when I take any recording from anywhere, and then I think I will hear it, but what happened? Recording will be submitted in my web mail, and it is becomes used, and after some days I become demotivated. How I can complete everything? It's not possible for me. So better you go for recording later. First you enjoy your live class, and then recording. And yes, options are available. So if you missed any, there are many problems in our life. Okay. Another things, if you think that I will not give in the June exam, also you can join. Because if you think that you want to do a good task, okay, so you should not make delay. You should not make delay because you don't know what will be the next time, how your life would be there. Okay, so thank you, Dr. Nafisa. Okay, so it is the way, by this way you should go. Okay, so regular class and regular read one things, but I want to say that the materials are not so small that you will easily read it. It's not like this. Okay, it's not, it's a huge. So I should say that don't go very deep in first way. Don't go in deep. Just go superficial first. Read, just one time read. Okay, and run with me. Just one time read. After you completion of read, so how you proceed? So first of all, you go through the PDF file what I will provide. After then you check the case book. After then you go for the recall file and then pediatric guideline. So this should be the way. When you complete one time, so after that when you revise it, it becomes very easy. Okay, and it takes too long, like too much short time. I can remember that whole case book I need whole case book reading, I need only 2 hours before exam. Because I know where is the things, what should I have to remember. Okay, so by this way you have to read. Okay, it's not very difficult exam, but not anytime. Not take anything very easy, then you will be in the hole. Don't take anything very easy and superficial, but don't think that it is very difficult. It's actually very easy exam because it is theory exam. You have option, so you have to give you have to click the right one. But if it is like not the theory exam, so in that cases it could be takes time. Okay, now I want to see the question. Okay, thank you, Dr. Nafisa. Approximate class duration. Okay, so approximate class duration is at least 1.5 hours, 2 hours. Okay, sometimes it can be overshoot, but very less. Usually we complete it, okay, 2 hours. So I don't like to take a one day very long class because concentration is a factor. So we cannot make concentration long time, or we have families and many things for the students, for the sake of the students. So I take it 1.5 hours to 2 hours. Okay. And then Science of Pediatrics books is good books. Okay, if you read it, you find it immersive. But for before exam, it is not the good books, just before exam. Okay, so it's the book, just your theory conception, theory of science. That is for the task exam, it is the book, and important things is the box, some boxes there. What is the earliest time to apply for clinical after passing theory exam? You can apply, but getting seat for clinical nowadays very difficult. So it takes usually 2 years. Okay, usually 2 years after completion of the theory exam. And clinical exams preparation time is at least 1 year. It is not like theory exam. So you can apply anytime, anything you can apply, but they have to accept it. Okay, this is the things. So the clinical is different. I think I answered this question. Do we need anything instead of the under anyone else? So training certificate is not needed, but you have to have a like boss, or you have to reference. So reference means you do not have to submit anything, but just names and post, and then mail address of your supervisor. Okay, so if anyone, it is for the clinical exam only. For the theory exam, no reference needed. Yes, I am saying it is not needed OET or IELTS. Very much clear. Okay. What is the approximate date after June diet mean after 6 months? After 6 months, what is the approximate date after June diet? Okay, so June diet, October, and also February. So this is the exam date usually. Okay, but they do not give the exam date at least 2 months before they or 3 months before they of the exam date they give it. But if you go through now, you can't get any exam date. But usually it happens June, October, and February. Yes, there is a mock exam in the in course, whole course after when you prepare for the when you book the exam and before the exam date, I will take it. For clinical preparation, okay, clinical preparation is here we do not want to take clinical preparation. So because it's different things, okay, you can after completion the MRCPCH theory, you will think over it, but it's possible. No, you without any UK training you can do it, but without any training you can completion of the clinical exam. I think it is will be difficult in your own country. At least you see some patients, common patients, but if you did it without training, if you did any like MRCPCH without training, if you complete, you can work in the NHS, okay? Because we know that patient management is, we should know about something in the patient management, okay? So I think we take the, thank you everyone who joined here. Thank you everyone. And now we will go for the our scheduled class topic. So I think if anyone want to leave, okay, they can leave, okay. But I want to just give a 5 minutes break, okay. So after 5 minutes break, we will again like join. I'm not ended the session. Okay, so it will be continue, but after 5 minutes we want to join, okay. At do you need any gap or we can continue? I can continue without taking any break. But if you need to any break, you can say. Right, Amos. I think today is for the Muslims, it is Shobe Barat. So maybe some, okay, so, okay. So we should continue. Okay. Thank you, everyone. Now, one thing's like I want to say before starting the new class. So please be loyal, okay, and ask me anything, okay. You know what is loyal. So you just ask me anything. You can share with me your problems, but usually I can comfortable with answering for the morning time, okay. And evening time, like I have class, so that times I cannot. Okay, so we our schedule was starting with the neurology, okay. Dr. Nafisa, I am here. Give my WhatsApp number. Okay, you can give the. Here is my WhatsApp number. Okay, so you can message me. Okay. Okay, I think the screen is visible. Okay. So first of all, for neurology point of view, you see it is the syllabus from the RCPCH side for the neurology. Okay, you can follow this. And this is the important topics, and you will get Science of Pediatrics books, pediatric guideline, forecast, task case. Here I mention it. Okay. So first of all, the embryology related, that is the anatomy related things, and it is actually from task exam. Okay. So we know that we can have some neural tube defects, and we already know that. I hope that anencephaly means we do not have cerebral hemisphere. There is some developmental defects of the cerebral hemisphere and most of the cranium. And encephalocele is midline defects where caused by the failure of the fusion of skull. Okay, but never ask questions from here, but we should know about spinal defects. This is called spina bifida. Okay, so spina bifida means you should know where is the problem. Spina bifida. Where is the problem? Your problem in the vertebral arch. So this is the things you should know. And here spina bifida when happen, it's a developmental defects, and also you will get that spinal cord will be here. You will get spinal cord defects. So spinal cord will be defects is there. So we will get some features of spinal cord problem clinically. But spina bifida problem is a developmental defect. So we get these features after birth. So how can we find it? Like after birth, what's the problem we get? So first of all, we get some skin changes. Sometimes we get some teethard. So we get some lipoma type defects. Okay, so totally we get defects is there through the skin, we can say. Okay, so it is divided by this way that when we get that it is the defects of your vertebral arch is covered by the intact skin, in that means it is occulta. But sometimes the problem where spinal cord tissue or meninges protrude through the skin, you can see it is visible. In that cases, it is called cystica. Okay, so we get what is occulta, what is cystica. Now, if you go for where it is commonly occur, your spine is extending from brain to spinal cord. So problem is mainly over the lumbar spine. Okay, and here also we know that there is two things, meningocele and myelomeningocele. Where myelo is there, it means neural tissue is involved. Okay, neural tissue is involved, then it is myelomeningocele. But when the meninges is involved only, then we can call that meningocele. But meningocele here, you should know that here no spinal cord is involved. Okay, some defects is there, but no spinal cord is involved here, meningocele, because spinal cord itself is a neural tissue. Okay, so spinal cord defects is a developmental defects, and from here I just want to clear it that spinal cord defect is a developmental defects, and if we go through this, then in that cases we should know there is some occulta and cystica. if intact skin there, then we can call it occulta, spina bifida occulta. Okay, and hairy patch, you will get it over the skin. And if we go for other things, so it is not occulta, it is, so in that cases there are two things, myelocele, meningocele, where someone having neural tissue spinal cord involved, it is called myelomeningocele, and only meningocele here, it would be covered by the dura mater, spinal cord is not directly involved. Okay, so these are the things, but questions from here, no questions you will get. So you get here, you see there is no red mark, so there is no recall questions from here. But this is a very basic things. Without knowing these things, we cannot proceed. Okay. Okay, please check your mic. Okay. Now, if we take these questions, it is taken from Science of Pediatrics books. Which one of the following statements are true and which are false? Okay, so anencephaly results from failure of closure of the anterior neuropores. So what does it means? Is it true or false? Okay, so what do you think? Is it true or false? And then myelin develops from birth. Is it develops from birth? That means after birth, myelin develop and it's proceed. Neurons migrate long myelinated bundles to their eventual position of the brain. The maximum number of synaptic connections are present at term, and retina originate from the forebrain. So among them, what is right? What do you think? And why? So you can write it in your chat box. So anencephaly, yes, it is true. It is result from failure of the closure of the anterior neuropore, and myelin develops not from birth. It is develops after like it's not mentioned. Yes, other false. Yes, Dr. Rejuana. Thank you. So myelination starts and it is 36 weeks, only 1 to 5%, but it's not any percentage is not required for your exam. Okay, and this myelination will be continuing after birth, and it's called maximum up to 3 years, and it's complete this brain development, this myelination. So it is complete within the 5 years. Okay. So you see here, it is not from birth. So neurons migrates along the myelinated bundles to eventual position in the brains, not this myelinated bundles along the myelinated bundles. Rather, it will just proceed glial cell. Okay, it's called radial glia. Along the radial glia, the maximum number of synaptic connection are present at term. Is it present at term? Maximum number of synaptic connection? No. After birth, you do not take maximum synaptic connection. Actually, it is increase. Okay, and maximum early childhood. It is called, rather than at birth, it is maximum at the early childhood. At the early childhood, 2 to 4 years, so they having huge connection. They are having huge brain working. Myelination, synaptic connection is there. And retina originate from the forebrain or diencephalon. It is the diencephalon. Okay, it's not from the presencephalon. So it is very important, is it? It is mentioned in the Science of Pediatrics books. If you go through the books, then you get it that here, just you have to read it from here. Other than many things is written, many things, 2 lines from the embryology. But I don't think that everything you have to go through. It's not like that. Okay. But pathway of CSF flow is very, very important. We should know about the pathway of CSF flow because many questions are from pathway of CSF flow. Okay. Okay, so you will say, how is our pathway of CSF flow? Okay, So from lateral ventricle, if we take the lateral ventricle and then from lateral ventricle, how it goes? We have lateral ventricle. So it is right and left, okay? So if we take lateral ventricle, so two sides, lateral ventricle, after then the, which ventricle? Anyone want to know from you? So from there is three answered. Okay, thank you. Yes, third ventricle. So there is third ventricle. Okay. So here you should know that where what is the here obstruction. Okay, it is the foramen of Monro. Okay, so it is the foramen of Monro. Okay, get it? Foramen of Monro. You should know it because task questions, and it's very important, several time questions from here. So if any time there is obstruction in the third ventricle, then what happened? Like third ventricle obstruction, anything can obstruct it. So lateral ventricle will be dilated. Okay, as the third ventricle, the way of our foramen, this foramen become obstructed. Okay, so proximally will be dilated. So after third ventricle, then there is fourth ventricle. So here, what is the foramen in between the third and fourth ventricle? There is no, in between them, there is a between the third and fourth ventricle, there is a foramen. It is called aqueduct of Sylvius. Okay, it is called aqueduct of Sylvius. So aqueduct of Sylvius is something that okay, so in between the third and fourth ventricle, there is aqueduct of Sylvius. If anything can obstruct, like third aqueduct of Sylvius is obstructed, then the lateral ventricle will be dilated, third ventricle is also dilated. Okay. Then there are some foramens. After the foramens, it goes into the subarachnoid space. Okay, the subarachnoid space of the spinal cord. So it travels, the CSF will be travel around the subarachnoid space of the your spinal cord. In that cases, can you say which foramen is there? Foramen of Magendie and foramen of Luska. These things you should know for the exam purpose. Okay. So what happened? Our CSF is produced first lateral ventricle, then goes into third ventricle, then fourth ventricle. So in between the lateral and third ventricle, there is foramen of Monro, and in between the third and fourth ventricle, there is aqueduct of Sylvius, and from fourth ventricle, there is two foramen, that is foramen of Magendie and foramen of Luska, and it goes around the brain and spinal cord. Okay, also brain. Then it goes into the veins, venous sinus. Okay, so this is the whole process. Okay, this is the whole process. So it is right here. You have to just follow. CSF pathway is very important. Now we will discuss some more things that is not came in the exams, but we should have some conception. Just you see here, what is the things? Arnold-Cherry malformation, where cerebellum push down into the spinal cord. Okay, someone is waiting, I think. Sorry if I missed it. No. Okay, so here, what is the problem? You will get that your lower part of the brain pushed into the spinal cord. Okay, pushed into the spinal cord. It is the Arnold-Cherry malformation. Pushed into the your spinal canal. Okay, it is the Arnold-Cherry malformation. Then if we go for, you have to just remember when you just you imagine what is artery malformation, these pictures, okay, is pushed into the spinal cord. So it is also developmental anomaly. Okay, and the problem of Dandy-Walker malformation, here problem in the cerebellum, okay, cerebellar vermis, and you see fourth ventricle will be dilated. Cerebellar vermis, Dandy-Walker malformation having fourth ventricle dilated. Problem in the cerebellar vermis. There is also aqueduct of Sylvius. Okay, so where we get this aqueduct of Sylvius? Can anyone remember these points? Where we get aqueduct of Sylvius? In between which this foramina is there? Anyone? It is in between the some ventricle, okay? Yes, in between the third and fourth ventricle, okay? So in that cases, if it obstruct, then what things you will get? You have to just remember this. If you get any obstruction in the aqueduct of Sylvius, then you will get that as the problem in the obstruction, and so before obstruction, you will get the dilatation. So before starting the fourth ventricle, what you get? Okay, what you get? Lateral ventricle and third ventricle, okay? So dilated third ventricle, why fourth ventricle here? So you see, we say that lateral ventricle in between lateral ventricle then third ventricle. So it's like this. Okay, so lateral ventricle, third ventricle, then fourth ventricle, okay? So where is the our aqueduct of Sylvius? Where is the aqueduct of Sylvius? So the CSF will be accumulated above. So you will get lateral ventricle dilated, and third ventricle dilated. Okay, get my point? This is the things. Then hydrocephalus. There's questions from here again, but we should know that the hydrocephalus means we know that here excessive accumulation of CSF. So that means we know that CSF is the fluid which remain in a certain amount, but if it is more, then we call it hydrocephalus. Okay, so something problem in their production or the absorption. Okay, something in their production problem or absorption problem. So production or absorption. So if it is happen like there is some meningitis and the production absorption side become blocked, so there would be no absorption, fluid will be excessive. If there is some things which increase production, okay, so what happened? If there is some problem, so there is increased production, then what will happen? Then also there is hydrocephalus. So if there is any tumor, then also can produce excessive production could be there. So this is the main difference, okay? So choroid plexus tumor, we know that choroid plexus, it is a task question, okay? So choroid plexus is the place where, yes, so choroid plexus is the place where normally CSF is the CSF production is here. So if there is any tumor, it produce excessively. If there is any meningitis or hemorrhage, then there would be impaired resorption, then could be we get hydrocephalus. Okay, there are two things: non-communicating hydrocephalus and communicating hydrocephalus. So we should make it clear. So non-communicating means there is some obstruction. Okay, so there is obstruction in the CSF fluid. Okay, we get lateral, third, fourth. So what happened? Like you have sorry. So you get that you have a problem in your, okay, so you get that there is some obstruction, physical obstruction. So that means it cannot communicate. Okay, some obstruction is here. So from here, there is between the like total obstruction, so it cannot make communication. But if there is production problem and resorption problem, so they can communicate each other. Okay, so excessive production, but they can the flow will be normal. Okay, so this is the communicating hydrocephalus. So very basic things. Without this, you can't proceed. So for management purpose, just you should know that this is a management is a huge thing, so need multidisciplinary approach. And for the, especially for the hydrocephalus, if we think, then there is ventriculoperitoneal shunt. Okay, so in the ventricles and peritoneum. In the past, there is a ventricular atrial shunt was there, but nowadays it is not done. And you should know there is a reservoir. Okay, so if excessive production, then you can remove from the reservoir excessive CSF. So there is ventricle and there is peritoneal. So ventriculoperitoneal shunt is there. Okay, so they grow within the abdomen, it is also growing. So that means the baby having problems. So we will monitor, monitor their head size. Then if required, then we can give the ventriculoperitoneal shunt, and we can help baby as much as possible. There are different management options, but we do not have to know. Okay, so still we discussed some developmental problem, and we said that for the TAS exam, we have to read the CSF pathway and some developmental problem regarding these important things, that we get some hydrocephalus. Okay, so they are communicating, non-communicating hydrocephalus. Where is the problem here? Some TAS question is where, how it is produced. So choroid plexus. Okay. So, and also we discuss when there is obstruction in the pathway, what features we can get. Okay, which ventricles will be dilated. So from now, it is common for the edema and also many things, headache, many things, most important things that we will now discuss. Okay, and it is both for the FOP and TAS, especially FOP. Okay, so we get many things for the TAS now. FOP. So edema, do you know about edema? What is acute disseminated encephalomyelitis? So it is a condition where encephalitis is there. Okay, that means our brain materials having some inflammation. Okay, encephalomyelitis. So some inflammation is there. Not, I do not say that it is infection. If it is infection, then we say encephalitis. We didn't say it. We said encephalomyelitis, acute disseminated encephalomyelitis. So edema is there. That means there are some. Okay, so encephalomyelitis means there are some inflammatory condition, and so we will get the features like encephalitis. Okay, the features like encephalitis. So what is the features of encephalitis? We know that fever, vomiting, headache, these are the features of encephalitis. Could be seizure also. Okay, so this is very common. If we get it, we think that yes, it could be meningitis, encephalitis. We check meningeal sign, but you do not give, you do not take here or get any meningeal irritation sign. Okay, so no neck rigidity, no connectors, no neck rigidity. You do not get other sign. Okay, you do not get chronic sign, Buzlitsky sign. Okay, so you will get encephalitis. First of things that you will get encephalitis features. But why it is occurred? If you think, then it is occurred after viral bacterial infection. It causes inflammation in your brain. Okay, after some infection. Okay, after infection you get. So you will get it, and if you go through this scenario, then it will be more clear to you. So without saying, we will answer my question. Okay. So a 9-year-old girl present with acute encephalopathy. In the preceding 24 hours, she was noted to have some fever and vomiting. Her parents also noticed that she was slightly confused the evening prior to her visual loss. Some visual loss was there, okay? Neurological examination revealed no focal deficit and there were no sign of meningism. Investigation reveals that poor blood count is unremarkable. CRP very high, yes sir, very high. Blood urine cultures negative. CSF studies was everything negative. So what is the most likely diagnosis? What do you think? What is the most likely diagnosis? So I want everyone active participation because I said you. I discuss with you. Dr. Shaji, Johirul Islam, Luna, Shatabdi, Rejwana, Dr. Amma Sadiq, Dr. Salma. Okay, thank you, Dr. Salma, and everyone. Thank you. So it is the Adam. So why you get this Adam? Because Dr. Tanya, thank you. So here you get the patient having encephalitis type of features along with patient having previous any previous history they give. But you, if you, why not? It is the meningitis. You should know. Yes, Dr. Afroja Shuma. So why it is a total count? You see. Culture viral. So if you get it, any meningitis features, CSF studies, and CRP is high, yes, are also high, but yes, so no meningism. So take it simply. Without meningeal sign, also meningitis possible, but more common is meningeal sign. Okay, CSF is normal. Yes. So most likely diagnosis is ADEM. Thank you. Most likely mechanism involves pathologically. You should know it. So it is something inflammation. I already saw inflammation. So what do you get here? Direct spread of the virus, vasculitis, perivenular infiltrates of lymphocyte macrophage, small vessels, vasculitis, tumor spread to secondary malignancy. So which goes in more favor of inflammation? Which things goes more in favor of inflammation? Okay, very good. Yes, thank you. Thank you, thank you. Yes, very good, excellent. Thank you. So it is the C. It goes more in favor of our inflammation. So simple scenario, but exam questions is like this, okay? So we get before that some true false type of questions never asked in the exam, okay? But in the sub books it is discussed. Now we will discuss with the headache. Very important things. Headache. If I say which is most important from neurology, it is the headache. So actually we get a headache in the our day-to-day life. Also we get a headache. So as it is very important, I will write it. Although with this pen, writing is difficult, but I try so that you can remember more. Okay, so headache is different type. Okay, we have to know how to differentiate. They will give us a scenario and they will ask you which type of headache it is. So according to this, you will go for management. Okay, so mainly 4 questions from here. Okay, so first of all, the tension type headache. So it is TTTH. Tension type of headache is one type of headache. Their complaints is they will say bend type, bend like. So it is like it's pressing, bend like, tight. Okay. And sometimes it could be in the occipital regions also, like it's written in the books, occipital region, but more commonly it is over the forehead, like tightening. Okay. And neck pain could be associated. Neck pain even. Okay, neck pain. Okay. So if there is, you get that your patient having tension type of headache, you will get these types of problem. Sometimes they can precipitating factors will be there. So it could be stress, it could be tension, but sometimes it happen like after relief of the precipitating factor, the headache appear. Like you are very stressed whole day, you are taking much pressure, you have deal with the ER, and you get many patients, you do everything successfully, but at night the headache is appear. Okay, so it could be but you will not get any other features, like there is no early morning vomiting. Okay, you will do not get any features of like neurological sign is not there. So you have to sort out this, and it's not disturbing, your sleep will not disturb. Okay, so sleep will be good. So these things you have to notice. Why this headache occur? Okay, so it is some signals goes to the brain, and it causing contraction of your muscles around the head. Okay, so these mediators or signals goes to the brain is responsible, and not everyone take stress by the same way. Okay, but it is not something produced, it is not real, it's not like that, it's real things, it is the headache, it's real things, but it's goes signals and then it happen. Okay, so for this, what is your treatment? So first of all, you can give paracetamol and other things, and also you have to give like stress relief way. Okay, so gentle exercise could be helpful, and also yoga is it's written, and sometimes coffee can precipitate tension type headache. Okay, so you have to avoid which causing a tension type headache. And also it is said that tension type headache, whose persons having tension type headache, they will do not take excessive pressure in their whole day, they will divide their work. So main things is to reduce the tension. Okay, that, and now after these things there is another things which is called migraine. Okay, so migraine is there. So what is the migraine problem? So here also headache. Okay, and this headache could be two types, with aura or without aura. Okay, with or without aura. Which is more common with the pediatric age group? Do you know which is more common with the pediatric age group, without aura or with aura? It's very important questions for the exam. Nothing we discussed without exam is important, not, it's not like this. Yes, it is very important without aura. Although in the adult counterpart, it is different. Okay, so we should know that migraine without aura is 80%. Like you do not have to memorize the percentage, but I want to say how much common it is. Okay, but with aura is could be, we know we get some sounds, so we can feel sometimes vomiting then, so some autonomic features could be in between this. It's called some positive phenomena, could be some negative phenomena, like they go get positive phenomena, some zigzag line. Okay, and negative phenomena means they lost their visual field, something is there. Okay, but here migraine means chronic headache, it's not acute. Okay, so you get headache after doing duty, it's not migraine, so it's a chronic headache. Okay, and it could be moderate to severe. Okay, moderate to severe. But tension type headache that we discuss, it is mild and it is moderate to severe. So questions will give you some features. you know, FOP is looking easy, but the FOP passing rate is low because they give you some points, but it is not very elaborate. So among them, you have to make your diagnosis. And if you miss one diagnosis, then you miss the investigation, then you miss the treatment, everything you miss. So diagnosis is very important. Okay. And migraine means there is chronic headache. Okay. And it could be associated with some familial history. Why doctor, we cannot know exactly, but family history could be positive. So genetic association could be there, but it's not very much well known. Okay, here we should know this headache is moderate to severe, and another thing is when it is not without aura, in that cases we should remember that here you will get pulsatile nature. Okay, pulsatile, and it is unilateral. Okay, it is unilateral. So these are the difference. Okay. Here another important things I should discuss, that sometimes it could be like migraine is there, along with you will get headache is there, but they have episodic hemiplegia. Episodic. Okay, episodic hemiplegia. Episodic hemiplegia means they comes to you with one-sided weakness, and it normal within 72 hours. Then again, after some periods, you will get this weakness. You do not give any treatment, but patient becomes like there is no treatment for the stroke. That the patient will be okay within 72 hours. Is there any treatment? No. But these types of things is like we get the patient having headache associated with unilateral weakness, and then it would be normal after periods last 72 hours sometimes. So it is called hemiplegic migraine. Okay, remember this. You have to exclude a stroke here. You have to exclude a stroke. Like if you get any hemiplegic patient, hemiplegic migraine, you have to stroke. You have to exclude the stroke. Other than then you can think over it. Sometimes some persons having migraine associated with occasional abdominal pain. It's called abdominal migraine. Okay. Okay. So abdominal pain. So don't miss it. Okay. So what is the treatment? There are some painkillers you can give, NSAIDs, and strong painkiller may be needed, but some preventive factors is to know which is the precipitating. After that, you will remove the precipitating factors, and some prophylactic drugs is there. So prophylactic drugs is propranolol, well known. Okay, other than propranolol, what you get? There is yes, there is somatriptan. It's used. Yes, thank you. This is used. Okay. Pituitary is there. But they have to also need the relaxation technique, because sometimes excitation also a precipitating factors for the migraine. Okay. Now medication overuse headache, another things, medication overuse headache, medication overuse headache. MOH, medication overuse headache. So medication overuse headache means you have some headache. It could be tension type headache. It could be tension type headache. Okay, it could be migraine, anything. And you are taking painkiller, NSAIDs. So what happened with the continuous use of these drugs, which is called that when you get these things, okay, so NSAIDs is important here. Okay, so you are taking a headache, you are taking your NSAIDs, and it is prolonged at least 2 weeks, prolonged use of headaches. Okay, so at least 2 weeks, and the drugs is not working. In that times, you have to ensure that it is the medication overuse headache. For simple headache, you are taking always NSAIDs. So what happened if you continuously taking the, it can turn into medication overuse headache. So you withdraw the drug, the headache will be gone. Okay. Now we will discuss with idiopathic intracranial hypertension. Very important. Okay, idiopathic intracranial hypertension. So idiopathic intracranial hypertension, remember this is exam topics, like exam question is here. So what is the idiopathic intracranial hypertension? So here you will get headache, and you can see that problem is intracranial hypertension. So you will get the intracranial hypertension features. So what is the intracranial hypertension features? We know it is the nausea, vomiting. Okay, nausea, vomiting is there. So headache, nausea, vomiting. It's not like as an aura, but headache, nausea, vomiting could be there. And this headache is caused by bending. It's very important, this points: bending, coughing, any which is exercise. Okay, so that times our intracranial pressure more increased, and it's idiopathic intracranial hypertension. So headache, nausea, vomiting, you will get the headache would be more on the lying down. Okay, bending, lying down also. So here it's the headache features, how it could be. But another things is there as a intracranial hypertension, that is the 6th cranial nerve palsy. Okay, so if 6th cranial nerve palsy, what features you will get? Patient having 6th cranial nerve palsy. If our 6th cranial nerve is supplied the lateral rectus muscle, so if lateral rectus muscle is paralyzed, so we cannot move our eyes laterally, so there would be pseudo squint. Okay, there would be squint. Also, it can lead to diplopia even. Okay. So you will get the 6th cranial nerve palsy, and also you will get papilloedema as a features of idiopathic intracranial hypertension. So here I want to say that idiopathic intracranial hypertension, we will get headache, we will get nausea, vomiting, and the headache is the way which is more on lying down, bending and coughing. And then as a features of intracranial hypertension, we get papilloedema and 6th cranial nerve palsy, so that there is squint and diplopia. This is the intracranial, idiopathic intracranial hypertension. Yes, squint is there. Yes, thank you, doctor. So it is there. So if there have squint and diplopia, there could be visual loss. Okay, blurring of vision. Okay, but remember, you do not give other neurological findings, only 6th cranial nerve palsy, but you do not get patient having weakness one side of the body, upper motor neuron sign is present. Okay, you do not get this. Why it is called idiopathic? Why it is called idiopathic? The cause is unknown. Okay, the cause is unknown. But remember one thing, as idiopathic intracranial hypertension, we will get papilloedema. Not always 6th cranial nerve palsy, but you will find the papilloedema at least. But it is not related with the pressure of the CSF. Not directly related with the CSF pressure, but usually we get the CSF pressure is high here. So what is the level which is normally it could be? So it is normally less than 25 for the normal person, but for obese person it is less than 28 is normal. So CSF would not to be must high, but if you get it, it points your favor. Okay. Okay. Now we will discuss the investigation for idiopathic intracranial hypertension. So for idiopathic, you have to say that times you have to confirm by the MRI brain. MRI, remember, for suspected idiopathic intracranial hypertension, you have to do the MRI, and also you have to do the magnetic resonance venography. So you want to know that is there any thrombosis is there or any tumor is there. So you have to exclude this tumor and thrombosis. Okay. These two things you want to exclude. Then you can say it is idiopathic. Otherwise, it not to be idiopathic. But yes, you have to know that there could be sometimes associated with some drugs. So drug level, you can do like steroid can cause idiopathic intracranial hypertension. So you have to exclude this steroid. Sometimes hypothyroidism could be associated. Sometimes obesity is an important risk factor. Not forget this, obesity. But obese and not like this, but obesity is important factors. Okay, and these two things are important. Some metabolic association could be there. So you can, if clinical indicated, you have to do for investigation. So now what is the treatment? So treatment is acetazolamide. Never forget this, acetazolamide. So acetazolamide is, it's called carbonic anhydrase inhibitor. It is not a directly diuretics, but act as like diuretics. Okay, carbonic anhydrase inhibitor. Okay, then acetazolamide you can give. Other than, you can also use furosemide. It will reduce your CSF pressure because our problem is our patient having intracranial hypertension. Okay. So you have to reduce this hypertension, then you will go for furosemide. And also you can go for topiramide. Okay. You can go for topiramide. These are the things. But if it is not successful, so topiramide cause anorexia. So your obesity will be reduced. It will help to reduce the idiopathic intracranial hypertension. But if it is not work, then you can reduce some CSF pressure by lumbar puncture. Okay, by lumbar puncture. And also there is, if nothing successful, then you can go for surgery. Okay. Okay, now we will check how you understand. Okay. So here 23 members will participate. Okay, inshallah. So what I said, everything is here. Primary headache is migraine, tension, cluster, different types. Secondary due to brain tumor, hypertension also could be drug induced. Okay, due to raised intracranial pressure, different types of there, but important things we discuss. Okay. What I said, everything is mentioned here. Okay. So you will contribute in this FOPCAS. Okay, it is the 47. You will get it at 47. FOPCAS. So Laura is a 14-year-old girl who attends her GP along with her mother. She has a 1-year history of intermittent headache. She described a tightening pain on both sides of her head that she scores as being 4/10. 0 means no pain, 10 over worst pain. The pain occurred approximately once a week, but in the past month has occurred more frequently. She has not vomited with the headache and there are no visual disturbance. The headache is promptly relieved by paracetamol and ibuprofen. Her height and weight are on the 98th centile. Her neurological examination is normal. Which of the following is most likely tumor? Most likely diagnosis? There is 1-year history. Okay, it is tightening pain on both sides of her head. And if you give score 4, not much serious pain here. First months more frequently. There is no visual disturbance. relieved by drugs. No, neurological exam is totally normal. So please write in your chat box what you are thinking now. No problem, everyone. Write in your chat box. Hafsa Afzal Khan, write in your chat box. You raised your hand. You do want to say anything? Open your mouth and say what is you want to say. Dr. Hafsa Afzal Khan, you raised your hand. Do you want to say anything? Okay. Now, what do you think? What is the cause? So, someone said idiopathic intracranial hypertension, but mostly say tension type headache. Okay. So I wants to go with you tension type headache. My points in favor is having a long history and the pain is not very severe and pain is tightening in nature both sides and patient having no neurological examination. Why not idiopathic intracranial hypertension? I said that for idiopathic intracranial hypertension, you should have this headache at least with the papilledema. Why it is idiopathic intracranial hypertension? Intracranial hypertension features is headache, vomiting will be there more on the morning and it will be more on bending forward or squeezing, these types of things. Okay, and it would be at least some features of idiopathic intracranial hypertension that should be papilledema or 6 cranial nerve palsy. Okay, so you do not have these things, so you do not take it seriously. It is you do not think it as idiopathic intracranial hypertension, so you will go in more favor of tension type headache. Now she returns 3 months later with almost daily headache which are not responding to paracetamol and ibuprofen. Examination again is normal. Her mother is requested a brain scan. Which one of the following is most likely diagnosis? Almost a daily headache, okay, not responding to paracetamol and ibuprofen. Her mother asked for a CT scan. So what is your diagnosis now? 3 months later, daily headache, not responding to paracetamol and ibuprofen. Is it intracranial tumor? Is it idiopathic intracranial hypertension, medication overuse headache, migraine, tension type headache? Now, what's your thinking? So a big club for you. Everyone said the right thing. So it is a medication overuse headache. Thank you. So you understand these things. Questions from here. Okay, mainly questions surrounding this way. Okay, thank you, thank you. Then after 6 weeks of appropriate treatment, Laura's headache back to her baseline. Okay, after 6 weeks. She returns, however, 8 months later to the GP. So after 6 weeks, it is becomes normal because drugs is withdrawn. But now after 8 months, you get it rapid access pediatric clinic with the following letter. Thank you for seeing Laura. So here you are working as in ER and you get from GP. Thank you for seeing Laura, who had intermittent headache for the past 2 years. However, over the past weeks, she headache been more persistent hours in the morning. The headache are not relieved by her usual medication. There has also been associated early morning vomiting and visual disturbance. Her neurological examination is normal, but on fundoscopy, she has bilateral papilledema. Her mother wants you to arrange a brain scan. Which one of the following is most important initial investigation? Which one of the following is most important initial investigation? One, they ask one. Okay, so here many persons say D. Okay, so yes. So now what's your diagnosis actually? Yes. So here, just be careful for these questions. There is papilledema, bilateral, okay? And there is morning vomiting, visual disturbance. So we know for idiopathic intracranial hypertension, you can get it. But for this, you have to exclude brain tumor and thrombosis, and by which MRI and venography. But lumbar puncture and CSF manometry having no role here. Why? Because you can get sometimes CSF high, but CSF could be falsely high, falsely low even. Okay, falsely high, falsely low. So it has, it can help you, like you get it as point of favor of your diagnosis, but it cannot exclude. Okay, it cannot exclude, like you get CSF pressure is normal, so you do not have idiopathic intracranial hypertension. I can say it. Okay, because it could be falsely high, it could be falsely low. So C is not the right answer. Okay, so now you get it, MRI and venography. Okay, so this is so I think we can stop here. In the next class we will do the next portion, like after then there is seizure disorder, epilepsy, different type of epilepsy. After then epilepsy is no, then some neurocutaneous syndrome we will read. Neurodegenerative disorders, cerebral palsy is important, and we will go for SMA. So as it is a first class, I do not want to go in much details from here, but in the next class it will be prolonged. We will, and today is actually for the Muslims some thing, it is special, we have to pray. Okay. And next class, so we will just keep your eyes in the group, but it is thank you everyone, but it is for the, actually it's there I running a course. I don't know you know or not, please give me a message. It's only for the my course, but I hope if you feel it beneficial, I will frequently arrange some free meetings also. I think I can arrange it because the many participants are here. If they feel, then I can frequently arrange it, but it's not possible to give all the time. It's not possible, but you can feel free to ask me any questions anywhere if you have any difficulties. Okay, so this is my number. I think here you can get my WhatsApp number. Okay, I do not check usually Telegram, so even Messenger, more I am feeling comfortable with the WhatsApp. So thank you everyone. Okay, inshallah soon we will meet and discuss more about this, and you have to read it. I hope you will, before class, if you read it, then it will be more easy for you and get prepared. Okay, thank you everyone. If you have any query, please ask. I can give some time more. Thank you. If no query, then we can take help. Okay, so good night everyone. Okay, inshallah soon we will meet. Thank you.